Okay, so this recording is going to be on the central nervous system, and we're going to go deeper into the central nervous system and sectional anatomy. Okay, so looking at the anatomy of the CNS is divided into the brain and the spinal cord. So the brain is central nervous system tissue composed of two main portions. So there's gray matter and white matter. So the gray matter is the outer portion of the cortex, where the white matter is the inner portion. The brain is divided into the cerebrum, the cerebellum, and the brain stem. So the cerebrum is the largest part of the brain, also known as the forebrain. The surface convoluted into sulci and grooves. And there's the midbrain. It's a stem-like portion that joins the cerebrum to the pons and the cerebellum. There's a longitudinal sulcus that divides the cerebrum into right and left hemispheres. And there's the corpus callosum, which is a large band of nerve fibers between the right and the left hemispheres. The cerebellum makes up the largest part of the hindbrain, along with the pons and the medulla oblongata, separated from the cerebrum by a long transverse cleft. There's the pons, which is the upper portion of the hindbrain, commissures between the cerebrum, the cerebellum, and the medulla. So the brainstem, it consists of the midbrain, the pons, and the medulla oblongata. So the medulla oblongata extends between the pons and the spinal cord, so it connects the two. If we look here, you can see this is the corpus callosum right here. You have your cerebrum and your cerebellum right there. And we have your midbrain up top with your pons and your medulla oblongata, which goes down into your spinal cord. So the spinal cord is a slender, elongated structure, consists of inner gray cellular substance and outer white fibrous substance. So the gray substance forms an H seen on a transverse section. So if we cut it, you can see it, and I'll show you what that looks like. It extends from the brain to L1, L2 space in the lumbar spine. And there's the conus medullaris, which is the pointed end of the spinal cord at that level of 1, 2. There's the filum terminal, which is the delicate fibers portion that connects the terminal tip to the coccygeal segment. So it holds the spinal cord in place and keeps it pulled down. Otherwise, it would just spring up. So it's connected to 31 pairs of spinal nerves. So they arise from the roots on each side of the spinal cord and is transmitted through the intervertebral and sacral foramina. There's also the cauda equina, which refers to the spinal nerves below the conus medullaris. So you have your conus medullaris, which is your spinal cord, and then it ends at L1, L2, and then you have your cauda equina, which has the spinal nerves just kind of floating in the CSF. And you have your filum terminal that holds the spinal cord down, and it connects to the coccygeal segment. So this is what your spinal cord looks like. Your gray substance is here, that's that H, and then you can see you have your posterior nerve root and your anterior nerve root coming out, and you have your white substance all around, which is the fibrous tissues. Meninges. So there's 3 continuous protective membranes that enclose the brain and the spinal cord. So there's the pia, arachnoid, and subarachnoid space. So the pia matter is the inner sheath, highly vascular and closely adhered to the brain. So you have your arachnoid, which is a delicate central sheath, and then your subarachnoid, which is the white space between the arachnoid and the pia. It is continuous with the ventricular system. So your meninges, you have your subarachnoid cisterns. So it's the area of the subarachnoid space that are increased in width. So you have your cistern magna, which is the widest subarachnoid cistern. It's located in the lower posterior fossa between the base of the cerebellum and the dorsal surface of the medulla oblongata. It runs right between the two. You have your meninges. So your dura mater is your outermost meningeal layer. It's strong fibrous, and it's separated from the arachnoid by the subarachnoid space. It's separated from the vertebral periosteum by the epidural space. These spaces do not communicate with the ventricular system. The dura has four major partitions. There's the phalanx cerebri, phalanx cerebelli, tentorium, and dural sac. So the phalanx cerebelli runs through the longitudinal fissures and supports the cerebral hemisphere. So it runs right down the middle in that longitudinal fissure. So the phalanx cerebelli separates the cerebellar hemispheres, the tentorium, and tentorium easy to remember because it's tent-shaped, and it goes around the cerebellum and to separate the cerebrum from the cerebellum. There's the dural sac, which encloses the cauda equina. The ventricular system. There's four irregular fluid-containing cavities. So you have CSF within these cavities. It's tissue fluid of the brain and spinal cord that surrounds and cushions the CNS. The ventricles communicate with each other through connecting canals. So we'll talk about those in just a minute. The lateral ventricles, there's one on each side of the mid-sagittal plane corresponding to the hemispheres of the cerebrum. There's the interventricular foramen, which connects the lateral ventricles to the third ventricle, also called the foramen of Monroe. The third ventricle is a slit-like cavity, somewhat quadrilateral in shape. It's situated in MSP, just inferior to the lateral ventricles. And I'm going to show you what all this looks like. You have your cerebral aqueduct, which connects your third and fourth ventricle. And it's called the aqueduct of Sylvius. Fourth ventricle is a diamond shaped and located in the area of the hindbrain. It's anterior to the cerebellum and posterior to the pons in the upper portion of the medulla oblongata. Median and lateral structures is where the CSF exits the fourth ventricle. Okay, so here's what it looks like. So it doesn't make sense until you see the whole thing. So this is your ventricular system. So you have your anterior horn, you have your body of your lateral ventricle, and you have your posterior horn and your inferior horn. So anterior, body, posterior, inferior. We look here, you have your interventricular foramen. So here you go from your lateral ventricle to your third ventricle. And then here's your third ventricle, and you go down your cerebral aqueduct down to your fourth ventricle. And you can see the shape of the fourth ventricle. It's diamondish. So there you go. There is your ventricular system. It's easier once you see it. So when we go through sectional anatomy, you'll be able to label this very well. All right, so imaging procedures. We do some procedures in radiography. We do myelography, CT, MRI, and then there's vascular interventional procedures also. So when we do radiography, we could be doing it to look at trauma, pathological changes, degenerative conditions, post-operative changes. We should always do images before we actually inject contrast in. So one of those standards. So myelography. General term used to the radiographic examination of the CNS structures situated in the vertebral canal, requires contrast introduced into the subarachnoid space. We make a puncture usually around L2 to 3 or 3 to 4. You can also introduce it into the cisterna magna at C1 and the occipital bone. I've seen that once. It made me very nervous. But the reason why we do it at L2, 3, 3, 4 is because the spinal cord has ended and now we're in the cauda equina. So we're not puncturing the spinal cord, we're below it. Okay, so usually performed as outpatient procedure, patients held for recovery 4 to 8 hours, then released to go home. It's being replaced by MRI. We can do myelography and MRI without contrast, which is really nice. We still use myelograms for patients where they can't have an MRI. So contrast is generally water soluble, non-ionic. There is iodinated medium, room, and usually the contrast has an M on the bottle, so make sure you have the M. And there's different concentrations based on if you're doing a cervical spine or a lumbar T-spine. So make sure you find out exactly what your doctor wants. The room should be prepared before the patient arrives, so make sure you clean the table, put your footboard on, put your shoulder supports on, and that you check and make sure your equipment's working. And you want to make sure that the image intensifier doesn't get near the patient's skin. So after the doctor started, you're going to lock the tower so it doesn't contaminate. Rarely do we pre-medicate patients, only if they're super anxious or in a lot of pain. Patients need to be well hydrated, and you need to tell the patients that when the needle goes into the cauda equina, that sometimes, most of the time, they'll jump. They'll get like a zinger down their leg. That means that we're in. So that's a good thing. I always tell them that's a good thing. When you feel that, we know that we're in. So we usually make cross-table lateral x-rays of the spine so we can see exactly the stenosis for the doctor to go in easier. We usually do it prone. We'll put a pillow under the abdomen to open up the joint spaces of the lower spine. You can also do it with the patient in like a fetal position laying on their side. So a lot of times we'll do that with them laying on their left side for MS patients or young patients. Okay, so we use a local anesthetic, numb the area, we insert a spinal needle. CSF a lot of the times is withdrawn. If it's anything for any kind of meningitis or MS or anything, we're going to draw fluid out and then we're going to inject fluid in. So we'll take the needle out, we're going to angle the table as we use gravity to move the contrast around, and we're going to roll the patient several times to coat the complete CSF. And then we can take images. A lot of times I'll have us do cross-table lateral and obliques of the spine of concern. So if contrast is moved to the cervical area, the head is positioned in acute extension, so you're going to have them lift their chin up as far as they can because you don't want the contrast going into the ventricular system of the brain. It causes severe headache. It irritates the meninges there and severe headaches for these people. We watch the patient and we keep them in a 30 to 45 degree angle in bed, and we keep them there for several hours. And we check to make sure that there is no leaking at the puncture site. If they have a spinal leak, they will get a headache, very, very bad headache. So looking here, you can see there's some stenosis. This is a lumbar myelogram, and we've got some stenosis there. You can see how narrow it is for the nerves. CT is common for brain scans with and without contrast. So we look for neoplasms, metastasis, we look for AVNs, avascular arterial venous malformations, demyelinating disease, such as Parkinson's. We'll look for MS, seizure disorders, hematomas. We do scans without any contrast to look for dementia, trauma, hydrocephalus, and acute infarcts. And CT of the brain primarily useful to demonstrate the size, location, configuration, and surrounding edema and mass lesions and mass effects. So it's a modality of choice for evaluation of hematomas, aneurysms, ischemic or hemorrhagic strokes, and acute infarcts, often used to first evaluate head and spine trauma. CT is very fast and it gives us information immediately, which we need a lot in trauma. So very accurate diagnosis of acute intracranial injuries, so contusion, hemorrhage, and fracture. And it's also used in conjunction with conventional myelography. So you do a myelogram, we usually send them to CT and we'll scan the patient so we can get better detail. So here you can see we have something nasty. There's ring enhancement right here. We have mass effect, and we have some necrotic brain tissue. So this is all dead tissue. So this looks like a cyst of some sort with ring enhancement, so it's not good with mass effect. And there's a little bit of blood right here. So yikes. All right. In the spine, it's used for assessing demyelinating disease, a lot more sensitive than CT. Spinal cord compressions, paraspinal masses, radiation therapy changes, metastatic disease, herniated discs, congenital abnormalities. We look at the middle and posterior cranial fossa abnormalities, acoustic neuromas, pituitary tumors, primary metastatic neoplasms, hydrocephalus, AVNs, brain atrophy. Anything with the CNS, MRI is really, really good at. It's very sensitive, so really good at looking at abnormalities. So I was looking at this image, and I don't have exactly what this image is, but I'm looking, and this is your spinal cord, is the gray coming down. And you can see here the spinal cord ends at 5-4. So between 3-4, the spinal cord ends. The spinal cord is supposed to end up higher, usually around L1, L2. So 5-4, 3-2, 1. So the spinal cord is supposed to end here. So we kind of have a long spinal cord. So it's supposed to be up here. It's not supposed to be down here. I thought that was kind of interesting. It's like, that's weird. All right. Vascular and interventional procedures. It's useful in the assessment of vascular abnormalities, vascular tumors, and vascular abnormalities or occlusions, generally used for non-invasive procedures or if more information regarding vascular is needed. So interventional procedures can open an occluded vessel or decrease blood supply to tumors, AVNs, and aneurysms. So we can just take a look, or we can actually do interventional procedures and work on the areas of deficit or problems. So interventional therapy may prevent the need for more surgeries for the patient, which is really, really cool. So that's all of your central nervous system. Like I said, we're going to cover this looking at CT and MRI in your sexual anatomy class. So this is just a really good introduction. So make sure you read the chapter so you'll do well on your quiz.